to see about an most frequently encountered clinical entity that we encounter on OPD or inpatient basis. That is testicular microlithiasis. Testicular microlithiasis is an often encountered incidental finding on scrotal ultrasonography done for unrelated reasons, and we end up finding them on either one or both testes. TML is a condition that is characterized by multiple spectral calcifications within the testicular parenchyma that appear as 1 to 3 mm tiny calcifications. These arise from the seminiferous tubule lumen. It was first described by Doherty in 1987 on ultrasonography, even though multiple autopsy reports are available before this date. Histologically, it is composed of hydroxyapatite core of collagen fibers and glycogen. The significance of this composition is also there, which I will tell you in the coming sections. The postulated origins of the testicular microlithiasis include the insufficient capacity of Sertoli cells to phagocytize degenerated seminiferous tubular epithelial cells that leads to calcific formations in the seminiferous tubules, or either displaced spermatogonia that becomes calcific deposits, ectopic oocytes in dysgenic testes, undifferentiated or desquamated calcified cells, or a rapid cell turnover and an overactive immune response, that is an abnormally active Sertoli cell response leading to such calcifications. Coming to basics, basically we identify these entities on ultrasound using a 7 to 18 megahertz ultrasound probe, which is called high frequency linear probe, and we scan for these entities on a longitudinal plane of ultrasound viewing. According to European Society of Urogenital Radiology, it is classified into 3 types. The first is the limited variant, where there is less than 5 microcalcifications in a field of view, like here you can see 1, 2 and 3. Second is the classical variant, where you can see more than 5 in a field. Here you can see more than 5 obviously. Third is the diffuse variant, where the testicular parenchyma, where I am sketching it around, is studded with numerous microcalcifications throughout the parenchyma. The significance of the composition is that because of the composition, there is no post-acoustic shadowing of these microcalcifications on ultrasonography. Coming to the numbers on TML, the incidence in normal population varies between 5 to 10%. Usually we take it as 9% in general. The prevalence in general population is 4.2%, and it steadily increases with age. In cryptorchid patients, that incidence is 3.5%, while in acquired cryptorchidism it is 6.4%. In cases of prior cryptorchidism that were treated, the affected side is affected in 14% of cases, while the contralateral normal side, interestingly, is affected in 19% of cases. Testicular tumors are roughly seen in about 4.64% of microlithiasis cases, but the association is not that clear. The multiple genetic syndromes also have associations with testicular microlithiasis, the most common being Klinefelter syndrome, Down syndrome and McEwen-Albright syndrome. Klinefelter is associated in up to 17% cases, while Down syndrome has 36% association, and McEwen-Albright syndrome has 63% of its cases displaying testicular microlithiasis. The common implications of this entity would include its association with infertility or subfertility, the postulated association with testicular cancer, the need for follow-up and management of these entities. Coming to the first implication, that is its association with infertility. All correlations hereby that are being described are only proposed and taken from multiple sources and they are pending validation. Incidence of TML in infertile patient varies from 1 to 20%. The postulated mechanism would include the blockage of seminiferous tubules that can lead to inflammation, that can affect the blood supply to the testes and raise intraseminiferous pressure, leading to declined sperm quality. Multiple correlations have been observed, like physical findings like TML has its association with lower testis volume, sperm concentration, total sperm count and motility reduction in some studies. But based on these findings, the association with subfertility is still debated. Correlations with hormonal levels like FSH, LH inhibit testosterone, they also seem non-conclusive in multiple studies, because some studies show there are positive correlations, some studies show negative, some even show a equivocal relation between hormone levels and TML. Hence, standardized evaluation is still needed to arrive at conclusions. Infertile men with TML have a 18-fold increased risk of testicular cancer when compared to men without testicular microlithiasis. Hence, testicular biopsy may be offered in high-risk patients. Those patients would include those with testicular germ cell tumors, bilateral testicular microlithiasis, those that have atrophic testes, that is less than 12 ml volume, cryptorchid testis patients, and patients with spermatogenic failure. These patients can be offered testicular biopsy in view of increased risk of testicular cancer. Second comes the association with testicular cancer. The TML is proposed to increase the risk of GCINS, interestingly in the contralateral testes again. TML with risk factors like those that were described above have up to 20% risk of GCNIS. Half of these patients develop GCT in 5 years. Hence, there is a need to be vigilant in such cases. Coming to the last implication, that is the follow-up and management. I have taken from two sources. I'll give you the references in the next slide. One is the one source describes that when TML is not associated with any risk factor that were previously described, only regular testicular self-examination is recommended. While when TML is associated with risk factors, regular scrotal ultrasound and a urologist opinion with or without testicular biopsy and cryopreservation can be performed. When TML is found with risk factors and the age of the patient is more than 50, regular testicular self-examination is only advised, because the risk of testicular cancer is low after 50 years of age. When the testicular microlithiasis is symptomatic with a suspicious lesion, surgical exploration with testicular biopsy or osteectomy is recommended. Young patients with testicular microlithiasis and various other symptoms of testicular dysgenesis syndrome, they would lead biopsy. Osteectomy for testicular cancer and who have TML in the testes on the contralateral side, there is also a debate whether they should be observed or biopsied. This is based on risk factors and age and the presence of a suspicious lesion. This is one protocol that you can follow. Second is based on the European Society Urogenital Radiology classifications. First, if you see ultrasound findings showing less than 5 testicular microlithiasis per field of view, the testis is normal and there is no risk factor, then you can straight away discharge the patient. He does not need to do anything. When the testis is normal but the he has history of cryptorchidism, history of orchidopexy, atrophic testes or prior GCT, then he would in cases of prior germ cell tumor, he would need oncological surveillance, while in cases of cryptorchidism, orchidopexy history or atrophy of the testes, The patient is discharged with self-examination advice. In cases of genetic syndromes like Klinefelter-McCune-Albright syndrome, the follow-up ultrasound is advised at 6 months and 12 months. If there is no nodules more than 3 mm, the patient can be straightaway discharged. In case of the ultrasound showing more than 5 testicular microlithiasis per field of view, again, if the testis is normal and there is no risk factor, you can discharge the patient straight away. But in case of risk factors with the normal testis, you will have to advise the patient for annual ultrasound. Similar pathway can be followed for genetic patients with genetic syndromes. In case of diffuse variant, even if the testis is normal and there is no risk factor, annual ultrasound is advised. And in case of risk factors, annual ultrasound is still advised. When the genetic syndromes are there, there is a need for referral to a genetic specialist and a urologist who deals with these entities frequently. When there is a focal or macro calcification that is associated with the testicular microlithiasis, urology or an oncology input is mandated, and a close follow-up of 4 to 6 weekly duration is considered, and with a recommendation for either an MRI or a biopsy or orchiectomy. These are recommendations that are taken from the European Urogenital Radiological Scrotal Imaging Subcommittee. So I have taken these references from Arab Journal of Urology, where they have described a very recent article that describes the diagnostic and prognostic implications of testicular microlithiasis. Second was the European Urology Focus article that I had taken from 2000, that I had taken. It was published in 2021, and the last was the trends in urology and men's health. This article has given the European Urogenital Imaging Society guidelines for the management of microlithiasis. Thank you.